All right, we're back on the record. Looks like everyone is present, states present applicant, Mr. Garner. Mr. Udishin, you may proceed.
Thank you, Your Honor. I would first, what can I approach the witness?
Of course.
Dr. Glasnick, I want to show you what we've marked for Defendant's Exhibit 9 and Defendant's Exhibit 10. Without saying anything about them, do you recognize those documents?
Yes, I do.
Okay. And let me show it.
Did you call them defendants?
That's how they're marked. What are we calling our exhibits?
Kids, they don't make that.
Where did these?
Oh, they don't make an applicant
Applicant.
sticker.
That I found
I can get some if I need to.
All of these have defendants on it. So what we'll do now is just for the record to be clear that all of the previously admitted exhibits, which was 1 through 8, are titled defendants, and those are applicants. And so we'll just use the defendants, keep it the same, knowing that defendants equals applicants.
These pursuant to your subpoena?
Okay. This is his question.
pursuant to the court orders from, correct?
So this wasn't a part of the state's record at trial?
No, it was not.
Okay. Twofold objection, Judge. I think I know where you're gonna rule on the first one, which is, my running objection, that this was a part of the underlying court record. The second objection is that this is not the appropriate sponsoring witness for these CAT scans from the Texas Children's Hospital, particularly if they weren't, again, a part of the underlying, admitted at the underlying trial.
Is an authentication issue you're bringing up?
Yeah, Your Honor,
Someone.
these, if I could address that,
Sure.
so these are the CAT scans that Dr. Glasnick testified about before the lunch break.
But
And they're already, I believe they've already been introduced and accepted as evidence as part of a bigger exhibit, but I'm just pulling out these 2 pages so the court can look at
would
it.
that be number 3, the imaging files from Texas Children's Hospital?
Yes, Your Honor.
And had I known, I would have lodged my objection at that time, Judge.
Well, I mean, the imaging files from Texas Children's.
These are different.
No,
These are,
no, I'm sorry, these come from that. These are in that exhibit. Am I
That's correct.
right?
they're in that exhibit, but they weren't admitted in the underlying trial. It was obtained subsequently through their the court order, and, as
Okay.
additional records.
8 and 9 are admitted. That's overruled.
Okay, so, can I proceed here?
Yes, sir.
Dr. Glasnick, I'll hand you again, defendants, 8 and 9. First of all, are those the scans you were referring to earlier in your testimony?
Yes, this is the scan that says up in the upper right, Garner, Kalen, date of birth 12/3, Texas Children's Hospital, date of 2/26/2000 at 4:02 p.m. in the afternoon. And at the upper right corner, you see sequence 2, image 14 of 23, and sequence 3, image 13 of 23.
So you were talking earlier about a right occipital hemorrhage,
Correct.
and I would just like for you to hold them up and show, hopefully the judge can see it from there, but just point to what you're looking at, and then I'll hand it up, then I can hand
You're
it.
welcome to use the Elmo, and we can switch the TVs where we all are seeing what you're
Okay.
talking about.
Can you figure out?
If you, yeah, so if you switch
Put it over here.
on the Elmo machine itself, Mr. Coleman, would you show where the input button is, please?
Yes, Judge.
Yeah. see.
Which this right here is something, having Mr. Coleman show how to use the electronics.
Sure, he knows more than me.
He's come a long way.
Why do everybody keep saying?
Because you've come so far. I'm giving you props. Giving you some kudos. There it is.
Thank you.
And I also have that on my screen here.
Okay,
So,
put number 9 up first and we'll let.
and there's a pointer with the green. Let's go.
Okay. Oh, great.
Very, zoom it out.
Yes, you should be able to.
There, that's. Okay, so Dr. Glasnick, can you explain to us what we're looking at here?
Yes. This is a CT scan. It's X-ray technology, means you're using X-ray beam. So the baby is on the table with its feet towards you, facing up. So 9 o'clock is the patient's right, 3 o'clock is the patient's left. On CT scan, bone is white, brain is gray, water is black, and acute blood is whiter than brain. So this is the right posterior occipital area, and that blood is sitting right there. And notice how it kind of almost like mounds into the brain. That makes it epidural as opposed to subdural blood. And this little spot right there is the lambdoidal suture. That's the normal. Babies are born with the various skull plates separated by the sutures, and so that looks like this blood. If you look real close, almost seems to track itself down in between those. And I'm not doing very well with my pointer.
And if it's easier, you can do it right behind you.
Oh, okay. Oh,
You can look over there.
yeah. This is the brain itself, and normally you would see subarachnoid space with water about 3 millimeters thick, but the brain is so swollen that has all been squished out. You come down here, and this is this mass of epidural blood, and it almost seems to separate the two bones right there. This is was not mentioned. I mean, I just overlooked it or forgot to fill the sentence, or the transcriber didn't put it in. But this is clearly here to the right occipital area, and that would be confirming impact to this area, not necessarily a trivial impact to the area.
Okay, and let's show.
Oh, but the brain. Normally, the brain is not this dark. When the brain is not getting enough oxygen, a lot of your energy is involved in keeping water out of the cell. So if you run out of oxygen, water comes in, and water on CT is dark. So this brain here is much darker than it's supposed to be. But this is massive brain edema with this acute blood, epidural blood sitting right there and looking like it goes in between those two bones right there.
Okay, let's show Defendant's Exhibit 10.
And again, see,
So first of all, is this is not the exact same scan as before, but it's the same
no,
thing. To
What's
explain
the-
the difference.
well, CT does, they really neat. They put you in this machine and they start shooting X-rays at you from all different angles, and then they just like bologna slices going up, and then they push a button on the machine that flies it like in the sagittal section, and then they can do front to back. So what you're looking at is like a bologna slice, and these slices are I guess is about 5 millimeters. What am I saying? Each slice is 5 millimeters in thickness, so your slice of bologna is 5 millimeters thick, and this is where it is at. You see the date and the time over here, and this is sequence 2, image 14 of 23. So you could ask a radiologist, will you please pull up sequence 2, image 14 of 23, and this image would appear.
And it's the same blood, but it looks a little different.
Oh, yes, because the other one was slice 13. So this is the bologna slice next to it. So that blood is now not seen here, but you see this again, mound of acute blood right over, this is the other side, but this is clearly different, and it's wider than brain. It's not fluid. It is clotted blood up to about, could be up to 10 days old. Obviously, the history implies that it's would not be that old, but the aging of acute blood on a CT scan, if it's wider than brain, it can be 1 to 7 to 10 days old.
Okay, so in this case, I'm going to move on from these scans.
Right.
In this case, they didn't do an MRI, I think.
Correct.
So do you know why not?
Well, MRI you got to have sedated. It takes about 30, 40 minutes. CT scan takes a matter of a few minutes on a terribly sick infant. It may be a bigger deal to do an MRI. Back in 2000, I don't know what the standard was. Certainly by 2010, 2011, MRI, early MRI would be pretty standard.
So today they would do it.
Yeah, I think so.
Okay. Now there was some testimony from Dr. Stein where he was describing to the jury what the shaking was like, and he gave an example of a tomato in a can. Do you have some comments about that example he gave?
Yes, I think that was an inappropriate example to use, because if you had an egg or a tomato in a glass jar without surrounded by water, you shake it, it's going to bounce all over the place, crush, which is what the jury perceived he was demonstrating by that. But if you took that same jar, totally filled it full of water, and then put the tomato in it, so there's no air in that jar. In other words, much like the intracranial vault, where the brain is surrounded by water, not surrounded by air, and repeated shaking, the brain would not be bouncing off the side. It would not be bouncing around.
So today, do genetic factors or testing for genetic factors have anything to do with these types of evaluations?
Yes, particularly if the issue of you're always screening for easy bleeding, like hemophilia, factor 12, factor 9, and platelet disorders, or people who bleed too easily. But everything in the biological system is kind of like a bell-shaped curve. And you also have the people who clot too easily. That's called thrombophilia, clot loving. And there is a genetic workup. You can be genetically predisposed to easy clotting. These can be people who
Fracture.
He was offered 20 years and said no. Exploding head. This might be one of the most shocking legal decisions you'll ever see. And trust me, it only gets worse for
young women on birth control pills have a stroke, or someone who sits on a plane without getting up and walking around for 4 hours can have a clot in their leg, which can break loose. So this is the thrombophilia. So in any case where a venous thrombosis is an issue, there is a standard workup of protein C, protein S, factor 5, Leiden, I think it's LEIDEM, I don't know for sure, but there's a series of genetic tests that are done to make sure that individual is not specifically prone to clot.
And they didn't do those back in 2004. Okay, now, in Dr. Stein's testimony, he was asked a question by the defense attorney, and the question was, and in this case, obviously it was a right occipital hemorrhage, correct? And his answer was it was not a right occipital hemorrhage. Now, what you're showing us on these scans, is that a right occipital hemorrhage?
Yes, it is. It's epidural as opposed to subdural, but it is acute hemorrhage in the right occipital area.
Okay, so when he says it wasn't that, he's just wrong.
I think he's wrong or didn't understand I don't know if he looked at the imaging himself or not.
Okay. Now, I want to shift gears and talk about Dr. Patricia Moore, the state's other medical witness. And you understand Dr. Moore was at the Harris County Medical Examiner's Office and did the autopsy, I don't know, 8 months later or so. And so she had, I guess it's fair to say, less information to provide the jury than Dr. Stein did.
Yeah, she would have much less information to provide.
But nevertheless, Dr. Moore testified that these injuries were caused by shaking. You recall that was her testimony, and that she also testified that the only other thing that could cause these injuries besides shaking was a severe motor vehicle accident.
Right.
Okay, now I think you've already told us, but that testimony is incorrect.
Yes, that testimony was incorrect. What she would have had at her disposal 8 months later would be that the brain had shriveled up to the point of about 1/3 its original size, and all that would show would be a terribly damaged, shriveled up brains. From my background, there would be nothing on that to allow her to say what would happen 2 hours before, 1 hour before, 3 hours after presentation. But what she did have was when they sliced open the eyeballs and looked, there was residual of the of staining where the retinal hemorrhages were. So she would have had, and the testimony I thought I read was evidence of retinal hemorrhaging, which in the thought of the time would be that this is evidence of residual evidence of retinal hemorrhaging, and that would require a requisite component of shaking.
So even though we now know that's incorrect, at the time in 2004, she was giving testimony consistent with what was believed to be correct.
Correct, and I have to. There was comment about the staining in the eye, which is, I assume, I have to say that's what she was basing her opinion on there. But the brain would be so damaged and scarred at that point in time. I don't know that one could make much of a comment as to what the original event was. The X-rays were read, of course, as hypoxic ischemic injury without enough oxygen getting to the brain.
So you're aware that Dr. Moore, at the time that this writ application was filed, she recanted her testimony where she signed an affidavit saying that she would not testify the same way now based upon what her understanding is of the new science.
I've heard that, Tristan.
Okay. So she's not the only doctor that's given testimony in the past that supports some of the theories of shaken baby syndrome that has later decided they were wrong. I mean, that happens fairly frequently, doesn't it?
Not infrequently, and I think that many, I never testified for the prosecution, but I have colleagues who were testifying that shaking is real, testified for the prosecution, who then have now totally done an about face. Dr. Plunkett said he would volunteer to review any case he had previously said otherwise on any kind of appeal. So that, yeah, once you realize that things have changed, the ethical thing to do is to admit it and try to not make the same mistake again.
Well, so that's really my final question is just as an expert witness, as a medical professional, as somebody who testifies in court, what are you supposed to do when you realize that your testimony was wrong, because the science has changed or for some other reason? What should you do under those circumstances?
I don't know that I've seen it in writing, but I would think you should be willing to go back and volunteer to be involved in the revisiting of the case. You know, there may be other evidence, but if what your testimony implied is no longer adequate, it would seem appropriate to inform attorneys that a revisiting of the case might be appropriate.
Okay. Thank you. I'll pass the witness, Sharon.
Thank you, Mr. Houston. Would you hand me those two, and I'll keep them with this if anybody needs it.
Yeah, that was my plan, just.
Here it goes. It just takes it a minute. There should be two. Yeah. Perfect. Thank you.
Good afternoon, Dr. Lavnick. Please, I want to start by apologizing if I get some of these terms incorrect or mispronounce some of these medical terminology at any point. Feel free to correct me, please. Is it your testimony today that you can't shake a baby to the extent that you cause brain injury without there being a broken neck or some type of a fracture of a ligament in the neck?
My testimony today that without doing that kind of thing, that there is no experimental literature to suggest that the abusive shaking would be a primary cause brain injury in a previously normal child. I hesitate that because there's.
I'm sorry to interrupt, but
Your
in my word,
Honor, I'm going to object to him interrupting.
well, Judge,
Well, hang
I
on.
asked
So
a yes or no question.
I'm gonna,
Yeah.
obviously, there was some leeway given with Dr. Glasnick answering your questions and giving further explanation. At this point, let's just get whatever the question is, and then if you want to follow up with some further explanation, we'll get through it that way.
You understand, Dr. Glasnick, if there's some elaboration that you'd like to make with regard to any of the questions that I asked, Mr. Udishin can come back and follow up and give you the opportunity to elaborate. But for now, my question to you is a very pointed question, please, sir. Is it your testimony today that you cannot shake a baby to the extent that that causes a brain injury without there being some fracture of the neck ligaments or some break in the neck? Yes or no?
There is no evidence that that would happen.
Okay. All right. Now, could there be a trauma, a head trauma, an external head trauma without bruising?
Yes.
Okay. And in this case, you're taking the word of a convicted felon that the trauma that was caused to the head was striking that baby on the door frame. You're taking that and making your opinion, correct? Yes or no?
I am.
Let me ask it a different way. That's part of your calculation, right?
Well, I think I would like to say a little bit of orientation. My job not to prove or disprove abuse. Now, I'm taking the witness statement from the record.
Hold on, don't talk over each other.
Not responsive.
Look, there's going to have to be some explanation. So if it's, not everything is going to be bright line, I understand that, and I'll allow some explanation, but try your best, doctor, to just answer what Mr. Coleman's asking.
We're talking about the door frame and the defendant's version that the child, he struck his head on the door frame. You're basing the entire, at least part of your calculation, your conclusion on his representation, correct?
Oh, correct. I start with the history in the chart, and that's what I have to deal with. Is that what comes through?
So that's a yes, Dr. Gillespie. Right.
Okay.
Yes. Okay. Now, if that were not true, if you weren't taking that at face value, then that would, and it's not true, then that would change your calculation. That would change your conclusion, correct?
No. It changes. It's my conclusion. You want me to say that this is or is not abuse. My conclusion is that is impact there, whether it's accidental, whether it's a door frame, or whether it's inflicted, is not something I am here to decide. You are trying to make me prove it's abuse.
Just answer the question.
I promise I'm not trying to make this typical, Judge. I just want a yes or no answer. Judge, I think I made my point and I'll move on.
Thanks.
You've taken that story. Well, let me ask you this. Are you aware that, in fact, that story did change? Are you aware that initially this defendant told law enforcement that there was no trauma?
I received the first witness statement and the second witness statement, and that this appeared in the second.
Judge, at some point, I mean,
He answers your question.
I know, just this yes or no. Back to the last thing. You weren't there that day on February the 25th of 2000 when this injury was inflicted on Kaylin Garner, were you?
No, I was not.
Thank you, Dr. Lashley. You truly don't know what actually happened on February 25th of 2000, do you?
That's correct.
Is it possible that this defendant could have violently shaken 2-month-old Kaylin Garner that day?
It's possible.
Is it possible that this defendant could have violently shaken Kaylin to the point that he used repetitive motions and done so on a repeated basis?
I can't say he didn't.
Is it possible?
Yeah, I guess it's possible.
And let's talk a little bit about your, I've read your resume. Let's talk about your clinical experience. Do you have any clinical experience either evaluating firsthand or treating firsthand abusive head trauma in infants?
The last time I was a primary treating physician for small infants was 1980.
But have you had any firsthand, person-to-person experience treating clinical in a clinical setting, either evaluating or diagnosing abusive head trauma in infants?
No.
Okay. You understand that there is a difference between a clinical trial and a case study, correct?
Yes.
Please briefly explain to the court your understanding of what a clinical trial is versus a case study.
A clinical trial is my understanding. Let's say we've got a brand new drug and we want to try it out. So we said this group gets this drug and this group does not get this drug. So clinically, we give it here and see if we can document a result. A case study is where a case series is where you take a series of cases and analyze them and try to extract some kind of conclusion from them. And so that and in a case study series, there's individual cases, but in a case study series, you have to have inclusion criteria and exclusion criteria. In other words, you have to say what this case has to have embodied in order to have enough information to be included. And if, for example, you're looking at head injury and you want to know what MRI shows, if the baby did not have an MRI, he is not in that series. If he's not in the age range, he's not in that series. So that's a clinical case series.
Thank you, Dr. Galesnik. And would you agree or disagree that a clinical trial that examines a group or a cohort for over an extended period of time is more extensive, more detailed, I would say, than a case study? Would you agree with that?
You use the word clinical trial. We're not experimenting with abusing half and not abusing half. What you're referring to better is a retrospective case series or a prospective case series where you say that going forward, we're going to take, we might treat patients coming in this way versus treating that way.
If you're going to get a case series or a clinical, you know what, you're right, I was referring, clinical trial is the wrong term, a clinical research study.
Right.
That's what I meant to say. Right. Would you agree with me that a clinical research study is more in-depth, more extensive than a case study?
It's more extensive than a single case, but you collect your case series, whether you do it retrospectively or prospectively into the going forward, that would make a bit of a difference. I mean, for example, make clear a classically cited article is the Rook study where she said, I will do MRIs on 101 successive deliveries. So they take 101 births and do MRIs on birth on every one of them. That is going forward and reporting the results. A retrospective is where you say, we're going to go back and look at the last 100 patients where we diagnosed, let's say, abusive head trauma, and we analyze those in hindsight. So in looking, and this is very important specifically because what I would like to make is that when you are evaluating literature that is based on even a retrospective case review or going forward case review, they always have to say the range. In other words, we're looking at all the cases of diagnosed with UC head trauma between 2010 and 2015.
And
That is-
Dr. Glasnick, I'm sorry to interrupt you. Was a yes or no question. I can't let him go on, Judge. But you would agree, yes or no, clinical research study is more in depth than a case study,
A
correct?
single case study is
Yes, sir. Thank you very much. And then you talked about the literature. Publications is the next question I was getting to. In order to publish, say, for instance, a clinical research study in the Journal of American Academy of Pediatrics, are you at all familiar with that process?
publishing an article.
Yes, sir. Well, specifically with the American Academy of Pediatrics, AAP, if I've got that acronym right.
All right. The way that works is you.
Yes or no? Are you familiar with the process?
I think I'm familiar with the process.
Does that
That's what you're asking.
Does that include a review by the editorial board?
The editorial board has to approve the research. Yes.
Okay,
And then
thank you, Dr. Lesney. They approve the research. Does that also include a peer review, opportunity for peer review? Yes or no, Dr. Lesney?
so before it's published, it has to be peer reviewed.
Thank you, sir. Does that also include, if and when it's published, an opportunity for commentary to be submitted with regard to that particular public?
Yes.
So isn't it fair to say that the majority of what you've cited when you cited the studies by Coates and Atkinson and Christian and Benenbaum, that those were case studies, not necessarily published in the AAP journal? Is that fair to say, the majority of them?
Those were experimental literature,
Okay.
not published in the American Academy of Pediatrics, but published in Journal of Neurosurgery or biomechanical journals. There's multiple journals out there.
Thank you, Dr. Glasnick. And again, if they weren't published in the AAP journal, then there wouldn't be those safeguards or those guardrails like the editorial board review, like being peer reviewed, and also allowing for others to submit commentary on those articles.
That's absolutely wrong. You're absolutely wrong on that. You're
Okay.
absolutely wrong on that.
Okay, please go.
Okay. When I have published articles,
Yes, sir.
I rewrite our article, we submit it to the editor. The editor then looks across the world and identifies people who he thinks or they think might be appropriate to view the quality of this article to see if it's worthy for publication. They give their feedback to the editor. The editor then gives that feedback to the original authors, and a dialogue can develop. And where they say you should have said this, or you should point out that, or you should clarify this, and then